Originally from Peru, Dr. Montori completed his residency and endocrinology fellowship at the Mayo Clinic. And you may not know that he spent some time working as a research fellow with Gordon Guyatt in McMaster. He returned to the Mayo Clinic, where he's now a principal investigator with the CUR unit, which stands for Knowledge and Evaluation Research Unit. And there he applies his passion for caring for people instead of for just diseases by studying and championing the integration of evidence-based medicine, shared decision-making, and this concept of minimally disruptive medicine, which involves being aware of the burdens of the interventions that we put on patients in trying to help them and how things fit into their lives. Dr. Montori is the author of a book which you may be familiar with, Why We Revolt, A Patient Revolution for Careful and Kind Care. And he's going to be sharing that perspective with us today. So welcome, Victor. Thank you for joining us.
Thank you very much, Jessica. It's a lovely introduction, and thanks to all of you for spending this part of your evening with me. I am going to start. I'm assuming you can see this slide. This slide at the bottom has my email address and my Twitter handle, and these are two ways in which you're welcome to send me notes and questions or things if we don't get to meet you tonight or discuss the issues or concerns that you might have. It's important, I think, for any talk that relates to, particularly for specific diseases, to make sure that there are appropriate disclosures. Before I go, I think there's a question whether this will be recorded. I do not know that. I do not see the recording indicator, so please confirm that you're recording before I continue, and then you start doing the...
Yes, it is being recorded.
All right, phenomenal. Thank you. So we talked about disclosures, and at the CARE unit, which is our research unit, we decided since the inception that we would not take any for-profit funding. So that's that. I derive all of my personal income from, I'm a salaried physician at the Mayo Clinic. I have other roles, but I don't derive any personal income, or my family derives no personal income either from any of my activities. Let's start with some evidence. So this is a forest plot. For those who are less familiar with it, I'll guide you through it. Here at the top, you see the three outcomes that this graph refers to. For each of them, there is a line in the middle that is a line of no difference. These squares represent the best guess, the best estimate as to the true effect as estimated by each of the studies, which are listed here on the left. And on the far left is the year, sort of an unusual notation, but starting in 1998 going to through 2015. In black, you will see randomized trials. In red, the observational follow-up of those randomized trials. In green, meta-analysis of the original randomized trials, and in orange, the meta-analysis that were done for this particular study, which was published in 2016. For all-cause mortality, we notice that the most recent estimate that considers all the existing evidence accumulated from 1998, when the first modern randomized trial comparing tight glycemic control to less tight glycemic control was published, all the way to this particular study. When we look at this estimate, we see that the best guess about the effect of tight sugar control compared to less tight sugar control on mortality overlaps the line of no difference, indicating that we do not have a net beneficial effect of glycemic control on all-cause mortality. You can see there is variation across individual studies, but this has been pretty clear. One study shows a benefit by the square being to the left of the line of no difference. a benefit of tight glycemic control on mortality, and another study here, the ACCORD trial, demonstrating an increase in all-cause mortality with tight glycemic control. But at the end of the day, no effect of tight glycemic control. So achieving tight sugar control in patients with type 2 diabetes does not help them live longer. If we move to the middle column here for cardiovascular mortality, it's probably enough to know that about 70 to 80% of all deaths in patients with diabetes, this is of course statistics pre-COVID, all deaths in patients with type 2 diabetes, 70 or 80% of them are from cardiovascular causes. So you'll not be surprised that there's almost a mirror image, and at the end of the day, also no effect of glycemic control, no significant effect of glycemic control in cardiovascular mortality. On the far right, you have non-fatal myocardial infarctions. And here the answer is a little different. You see most of the studies estimate the effect of glycemic control to be beneficial in reducing the risk of non-fatal myocardial infarction. And you see here at the bottom, the best estimate is a significant result, a 16% reduction in the risk of non-fatal myocardial infarction with tight glycemic control. So the first piece of the puzzle I want to show you is if you look at the totality of the evidence comparing achieving tight glycemic control with less tight glycemic control on what are called macrovascular outcomes or cardiovascular outcomes, the result is either no effect or a reduction, significant reduction of about 16% in the risk of non-fatal myocardial infarction with tight glycemic control. This is the same graph, but this time looking at what are called microvascular complications. So these are the effects of diabetes, type 2 diabetes, on kidneys, on eyes, and on nerves. And now you're probably more familiar with this display, and you can go towards the bottom of the display looking at those green and orange bars, which are the pooled estimates of effect, and you can see that in none of these cases tight glycemic control makes a difference or has ever made a difference in terms of these outcomes. This is a bit strange because most of you who are somewhat familiar with type 2 diabetes and the evidence would have gotten used to reading in guidelines and other documents that we are confident that tight sugar control reduces the risk of microvascular complications such as the need for dialysis or kidney transplant, blindness, or amputations or neuropathic pain. And where we are not sure, or perhaps there's no benefit, is on cardiovascular outcomes. And I'm just showing you that the evidence demonstrates exactly the opposite. What I'm not showing you is that for some of the markers for these complications, the ones that I'm showing you now, the effect of glycemic control is significantly in the direction of benefit. But it's a bit strange that after 10 years and close to 30,000 patients randomized, we can't show a difference in outcomes that patients can perceive and will consider important to avoid. Taken together, one summary that we can make of the existing evidence for glycemic control in type 2 diabetes is that these trials, which by the way, they're all open design, in other words, patients and clinicians knew in which arm they were randomized, are able to demonstrate effects that are small and somewhat imprecise. There are no really relevant subgroup effects that one can glean from this data. And if one has to be optimistic, one might say that perhaps glycemic control may prevent some complications, particularly non-fatal MI, although it's pretty weird to prevent MIs and not prevent cardiovascular mortality. And perhaps there's a reduction in the risk of surrogate markers of diabetes complications that are microvascular in origin. But these benefits, if they are real, they must be very small and would take decades of burdensome treatment to achieve. There are a number of conclusions one can draw from this. Some more creative might think perhaps sugar levels, glucose levels, glycemia is like fever for an infection, and we've been spending a lot of time and effort treating the fever, and we've not really developed antibiotics yet. In other words, we don't have treatments to affect the underlying pathophysiology of diabetes. Those less dramatic may think that perhaps it is true that glycemia is the cause of these complications, and lowering and controlling glycemia is potentially beneficial, but boy, it's really hard to see inconsistent results, and if they are real, it will take a long time, and again, require a lot of burdensome treatment. So that brings us to our patients, and this is Maria Luisa, a patient that has been coming with me to all these presentations for a number of years. She is like me, originally from Peru, but she moved with her son and her granddaughters to Anchorage, Alaska. And the problem for us as we treat patients is not our ability to interpret the evidence and understand the numbers and all this other stuff, but really is the challenge to take care of people like Maria Luisa, and to take care of Maria Luisa, actually. And this picture of her, which is taken by her granddaughter, is quite striking, isn't it? Because it shows a large number of interventions, healthcare interventions on the right. And if one appreciates her expression, one doesn't walk away with the impression that she's particularly healthy. And when we see a patient like Maria Luisa, we've been instructed, we've been taught, and as clinicians, we're held accountable to optimizing this variable, hemoglobin A1C, as a marker of glycemic control to approach Maria Luisa. Well, I think there's an alternative approach, and I'm going to present you today an alternative approach for the treatment of type 2 diabetes that is not so centered in achieving glycemic control, a freedom that I can take based on the evidence I just showed. This approach starts by understanding how sick is the patient in front of me. What symptoms does this patient have? And as you know, patients with chronic conditions often have debilitating symptoms accompanying the chronic conditions that they have, such as pain, fatigue, insomnia. In the case of patients with diabetes, the possibility of having very high blood sugars that cause dehydration and tiredness, or hypoglycemia, low blood sugar, that interrupts their lives. We also look at the burden of treatment. How much work are these patients expected to do, and what capacity they have to do it? We also focus at health, not just diet and activity, but also, and very importantly, stress, or what is sometimes called the allostatic load, the stress that the environment puts on our bodies, in this case in the form of the saber-toothed tiger that is outside the cave, but in modern days decides to never leave. We also then look at cardiovascular risk. I already told you this is the main threat for most people with type 2 diabetes, and there are things we can do to reduce that risk with lifestyle, but also quitting smoking, treating hypertension, and using other medications. Then we might look at glycemic control, mostly to avoid those extremes of hypo and hyperglycemia, with a regimen that can be made to work in the life of people. And finally, if we are not successful, the challenge of deciding, do we intensify therapy, or do we approach something that we call minimally disruptive care? So we'll walk you through a few of this. I'm not going to go through all of this, but I'll go through a few of this that I think are more different than perhaps what is normally discussed. So we'll start with burden of treatment. This is from a project that Dr. Gabby Spencer did when she was a medical student and a master's student with her group. She's now a chief resident at Stanford University in California. And she put an application in patients with cell phones and asked them to report the work that they were doing to take care of themselves. And part of the study was to take pictures of what gave them work. And so patients took pictures of nutritional labels, because of course it's hard to compute the number of carbs or calories that they have to do as they combine different ingredients in producing the foods that they're going to eat. They also took pictures of some of the treatments that they were taking and some of the tests that they were supposed to do. This one is particularly interesting because the reason the patient took this picture was not because of self-monitoring, which is in itself quite a bit of work, because his insurance kept changing the glucometer and sending him a new one. And he had to then get rid of the old glucose meter strips and get new strips for the new meter, and then learn to use that meter, which, as you can tell from the buttons, it has the same interface as a Casio watch from 1981. But many of the patients took pictures like this, pictures of waiting in waiting rooms, waiting on hold, trying to overcome administrative barriers to get the care that they need, get an appointment, get an answer back from a question, waiting in the office, like in this picture, for their clinician to come in and see them. Waiting. It's almost like the healthcare system should have a recording that sounds something like, "Your time is not important to us. Please hold until our next available representative is ready to take your call." This patient took a picture of this cupboard, which looks like it's taken in the hospital, but actually that is a picture of her home and where she keeps all her supplies for her diabetes care. This patient wanted us to know that she had everything going on. She was physically active, she was eating right, she was doing everything that she's supposed to be doing, but then she had a problem with her foot. If she was sidelined, she started gaining weight, and so she wanted to tell us that sometimes, even under the best possible situations, you think you're doing things, and now the work that she had to do was all of a sudden became a lot more difficult to do. All this work that patients do has to make sense with everything else that's going on in their lives. And so they have to do this very fine job of weaving in the activities, the medical errands that we give patients, along with all the other errands they have to run to take care of themselves, take care of their families, and make sure that all that needs to be done gets done. Not happy with this substantial amount of work. Healthcare has decided that the patient is the most underutilized resource, which is like not only a terrible idea, but also a terrible use of English. And this underutilized resource could potentially do some things, take some personal responsibility, and get things done that will help us deliver better care. And so we expect patients to come prepared for their consultation, watch our wonderful, hilarious educational video, to bring questions and be ready to ask new ones as things get revealed, to record the visit, and then when they go home, they can review it. That way, if they're coming to see me, I can speak very quickly, and then they can slow it down for themselves and their loved ones once they get home. They can review the medical record and catch our typos and incorrect cut and paste. They can communicate via the portal, and that Fitbit that they have, they can transmit that data to us. We probably won't look at it, but it will keep them engaged. We will then ask them to self-measure, self-monitor, self-manage, to manage their appointments, their prescriptions, pay their bills, keep their family, important others informed, take care of significant others, and of course, to advocate for themselves and advocate for others. As you review this list, I hope it comes across that each one of this is a completely reasonable expectation. But the accumulation of all these demands placed on people who are coming to us not for fun, but because they're sick, is quite challenging. And of course, if patients don't follow through with this requirements, we kindly label them as non-compliant. We don't describe their situation as compromised by perhaps too much things that they have to make it work, and perhaps they couldn't. No, we don't describe that situation. We describe them. We describe their nature. We describe their character as non-compliant. And as patients go and visit other clinicians, that label follows them. As I talk to a colleague about this patient, I might describe her as a non-compliant patient who is being, I'm asking for your help with this, and my clinician's mind immediately goes to non-compliant patient. I can't help her. And so Maria Luisa will not get the care that she needs because we've overwhelmed her. So if we've overwhelmed her, that means that we've exceeded her capacity. So where does Maria Luisa and patients with chronic conditions get capacity to shoulder all this workload that we are transferring to them? And of course, which is the same capacity that they use to shoulder all the work that life throws at them. And here's a list of things that contribute to that capacity: a sense of purpose. You have no idea how often when we ask patients, what gives you, what are the sources of joy? What are the sources of joy in your life? You have no idea how many patients stop and think and never produce an answer. Some people cannot think of sources of joy in their lives. So if there's no sense of purpose, no source of joy, what motivates people to wake up in the morning and do all this work to take care of themselves? Of course, resilience, which many people think of it as a personal feature, but resilience oftentimes is a result of you and your community and how you are able together to bounce back from adversity. And in the case of patients and clinicians working together for a long time, oftentimes the resilience is something that is found in the relationship between the patient and the clinician, not just in the patient alone. Literacy, not just the ability to understand our handwriting or the signs of our hospital or instructions in our handouts, but also the ability to know when to take exception, when to cut corners, and to do so safely without any negative impact. The kinds of things that expert patients are very good at. Bandwidth, which has to do not with internet, but with attention, and a bandwidth that it tends to be very narrowly focused when people are under severe stress, meaning that other things fall out of focus and as a result may not receive the attention that they should. So a person that is going through a very difficult personal circumstance or family situation, they might not be able to take care of other aspects because they're falling outside of their area of focus. Physical health, mental health. If you have a bad knee, you have to limp your way to the bus station, and that will take you longer than if you didn't have that problem. And so you get to do fewer things in a day. Mental health, if you're depressed, you wake up and you walk through molasses all day long. And so, again, you get to do fewer things. Financial health, very important because money may not buy you love, but it buys you help. And without the possibility of hiring people or to do things for you, all the capacity that you have is your own, which of course is the same consequence if you are socially isolated and you do not know how to ask for help from the people that are around you. So it's interesting because then one of the things that we could do that is more productive is instead of labeling Maria Luisa as a non-compliant person, we can describe her situation as resulting in an imbalance of workload and capacity. And this, all of a sudden, is a much more productive way forward than the notion that people are non-compliant. Because with non-compliance, what can you do if somebody has the wrong character? But with an imbalance of workload and capacity, you don't have to be a clinician to know that there are two places where you can make a difference. You can try to reduce that workload or distribute it differently, or you could try to boost capacity and that way try to resolve this particular challenge to the patient's care. Now, one of the things that results in the excessive workload is how do we respond to Maria Luisa? You see, we have guidelines that tell us what to do. We have targets that we must achieve, for instance, the targets of glycemic control, and we have new drugs that probably we should be using, otherwise we're not staying on the cusp of our practice. But all of these interventions are actually designed for people like Maria Luisa, people with diabetes, people with renal problems, people with cardiovascular disease. They're indicated for people with the diagnosis of X. They are responses to the care of people like Maria Luisa. But that is not the job. The job that we have to do is to take care of Maria Luisa. And the reason we don't do a good job with that is while those treatments respond to people like Maria Luisa who share the same biology. The job is to match the care of Maria Luisa not only with her biology, but also with a deep understanding of her situation, of her history, of her values, preferences, and goals and aspirations. To care for Maria Luisa, we need to develop an understanding of both her biology and her biography. And that, to access that, we need her participation. And so as we think about how we might care, particularly for patients with chronic conditions, we need to think about a way in which we can develop an understanding of Maria Luisa's situation in her biology and her biography. And we have perhaps an expert in biology in the clinician, but certainly there is an expert in the biography of the patient who is the patient. If you want a more sophisticated definition of this, this method of care, of shared decision-making, it is a conversation, which of course is a fundamental human activity. It's a conversation that has a purpose, and the purpose is for clinicians to work out what to do, to formulate a care plan that makes intellectual sense. In other words, it seems to respond well to the situation that the patient is facing, and it does so in an evidence-based way. It has to make practical sense. It has to not overwhelm the capacity of the patient and be a feasible plan in the life of this patient. It has to make emotional sense. It has to feel like the right thing to do. This is the process, the mechanism, if I may, of shared decision-making, an iterative process in which patient and clinician work together to figure out what is the aspect of this situation that demands action, and also work together to figure out, so what are the actions that this situation demands. This iterative process continues until we can arrive at a sensible solution. So what can we do to notice what aspect of the, and to understand and arrive at a common understanding of what aspect of the situation demands action? Well, usually, again, we arrive at this conversation, but there's a few things that we can do to help with that. Here's something that we are just currently researching at the care unit, which is the use of these cards, issue cards, that patients select from a deck of about, I think there's 15 or 16 of these cards. They select them from a deck while they're coming in to see us, maybe select 1, 2, or 3 of this, and literally put the cards on the table for things that perhaps they want to say, but they don't know if they will be acceptable to bring up, or they now have developed the words to actually express, but they're important aspects of the situation that demands action. For instance, this card says, I struggle with remembering, taking, or managing my medications. There are things I would like to do but can't or won't because of my diabetes. I worry about my ability to pay for my health care. My diabetes limits my ability to work, do hobbies, or spend time with family and friends. Diabetes is impacting my sex life. This one is particularly interesting. We did a review of video recorded interactions between patients with diabetes and clinicians, and that 0 of those videos had any discussion about the effect of diabetes on sex life. Yet when we introduced these cards, this was one of the most popular cards, particularly among men with diabetes. And again, as I was saying, this process continues until we come up with a solution to that problematic situation, and we test that it makes intellectual, emotional, and practical sense to the patient. Another way of figuring out what's going on is more quantitative, is for instance what we do when we estimate a person's cardiovascular risk. And then we share an understanding of what that risk means. For instance, when I show a picture like this of a patient with an estimated 10-year cardiovascular risk of 21%, what I would say to the patient, look, you're in a room with 100 people just like you. If we close the door and open the door 10 years later and count, we will find that 79 people like you here in green would not have had a heart attack in that 10-year period, and 21 in orange would have had a heart attack in that 10-year period. I do not know if you're one of the green ones or one of the orange ones. Some people look at this and see, oh, there's more green than orange. Other people count individual numbers, look at the numbers here, and gain insight from that. Occasionally, a patient will identify one of these circles and say, "That's me, doc." So what are things we can do to help with the being of a common mind as we think about the actions that the situation demands? Well, for instance, when we have used a calculator like the statin choice decision aid, and we're trying to reduce cardiovascular risk, a tool like that might help us. We have other interventions now that help us reduce cardiovascular risk. This is a horrible, horrible graph. But this is typical of algorithmic approaches to medicine where, we clearly as a profession are begging to be replaced by artificial intelligence algorithms. And in this type of graph, patient preference and other things are really not displayed. What it's talking about here is now to the left, approaches to the management of diabetes that are independent of hemoglobin A1C, which begins to hint that even some of the establishment experts in diabetes are beginning to see that this A1C is not the whole story. But then to the right, you can see the A1C targeted approach. What's dominant in this graph is the presence of two new or relatively newer drugs for the management of diabetes, the glucoretics or Sgl2 inhibitors and the GLP-1 receptor analogs. Well, we could potentially figure out if those treatments, which have been shown to reduce the risk of cardiovascular events, belong to a patient. So we can use a calculator of risk very much like the statin choice. You're the first audience that's seeing the first glance of a new expanded version of our statin choice decision aid, now to account for interventions that are either pharmacologic or non-pharmacologic. That's why you see here, if you continue without smoking and you start meeting those statins, this is what you will see. So here's a patient that has a 10-year 12% risk of having a heart attack in the next 10 years. We would demonstrate this by telling the patient that they're in a room with 100 people like you. We close the door. 10 years later, we open the door. We count. There will be 88 people without heart attack, 12 people with heart attack. I do not know if you're one of the purple ones or one of the green ones. Now, if all of those people were to take statins every day for the next 10 years, let's just give them enough, close the door, wait 10 years, open the door again, count, we will see that the 88 people that were not destined to have a heart attack would have taken the medicine. Maybe their cholesterol would have come down, but they would have had no benefit because they were not at risk of any event in that period of time. And of the 12 people that were destined to have a heart attack, 9 of them will still get their heart attack despite taking the cholesterol medicine, despite seeing their cholesterol levels come down. And 3 people here in blue would avoid their destiny because they took the medicine regularly for those 10 years. I do not know if you're one of the green ones, one of the purple ones, or one of the blue ones. Now, it's very hard to do. I've tried this poll system here, but, it's kind of fun at the moment. Just think for yourself. If I was your clinician and I were to show you this, would you take the statins to reduce your cardiovascular risk from 12 in 100 to 9 in 100, taking a pill for the next 10 years? So think about that. I'm just going to guess that most of you would not. So why am I showing you that? Because imagine a much higher risk patient, say somebody who is at risk, a 30% risk at 10 years. And imagine that so somebody on the chat is saying, I wouldn't take that statin, particularly for the probability of harm. You can always, since the harms, as for all we know, are very reversible, you can always say that unless it hurts your muscles or hurts your wallet, you will take it. But frankly, the size of the benefit for many people is too small to even motivate them to take a pill every day, let alone one that might cause you difficulties or cost. So if you take a patient at 30% at 10 years, and you gave them a low dose statins like the doses that have been used in clinical trials of primary prevention of cardiovascular events, you might reduce that risk by about 25%, to 22.5, or by 7.5% in absolute terms. Okay. Say that that risk is still a little high, so you may want to offer the patient a higher dose of statins, which adds another 15% reduction, a reduction of about 4 points So now you start at 30, we're almost at 19%. Well, it's still a risk, so let's do something else. Let's throw in some aspirin. As you know, controversial right now if aspirin is net beneficial in primary prevention of cardiovascular disease. People are excited about the possibility that it might help with colon cancer, but for cardiovascular disease, falling a little out of favor. There's still some positive trials in diabetes, perhaps because it's easy and common and people are already taking. Maybe we can keep doing that. Well, that's another reduction of potentially 3% if that's true. Well, the patient has a bit of hypertension. We can treat that with antihypertensive treatments. Hopefully one drug will do, maybe we'll need two. That will give you another reduction of risk of about 3%. Notice that as we add interventions, we get a reduction in the return on investment. Each intervention gets a smaller benefit and smaller benefit and smaller benefit. The first few cut the risk by almost a third. We're still now at 13%, so we're about hitting half the risk. We learned that glycemic control can reduce the risk of non-fatal MI by 15%. So that's another reduction here. Now these 2 points, and now we're hitting about 11%. Oh, what about that GLP-1 receptor analog? That also reduces the risk of cardiovascular risk. And every patient with diabetes, according to that graph, should probably be taking it too. All right, let's add that in. Well, that will reduce it by another 1.4% to 9.6 total. What about those Sgl2 inhibitors, you know, the glucoretics, the ones that make you pee sugar and lose weight and look more beautiful, particularly at night? Well, that would reduce that risk to about 8.3%, in other words, by 1.3%. So again, notice that substantial reduction in the return for investment. Now, I can tell you that having been using the statin choice decision aid for more than 10 years, that when the risk of cardiovascular disease drops below 10%, most people are very unenthusiastic about taking one pill, statin, for 10 years to reduce their cardiovascular risk, let alone do all these things listed under 20%. But even you, when I show you that 12% risk, probably felt very, I'm going to guess, very unenthusiastic about starting treatment. And that was a level about here, where the glycemic control level is. So it's interesting because it suggests to me that, as you can see, there are all the things that we can do for patients. There's a point that depends on the patient, depends on the values and preference of each patient. There's a level below which additional intervention is not exciting, is not attractive, particularly as those interventions may, in fact, be cumbersome or expensive. Think about the Sgl2 inhibitors. You know, 2 in 1,000 risk of amputations, 1 to 2 in 1,000 patient-year risk of diabetes ketoacidosis. The last issue of the Annals of Internal Medicine shows Canadian data estimating it around 2 in 1,000 patient years. And of course, the feared and common urinary and genital infections with the possibility even of genital gangrene. And of course, these medicines are costly. Metformin or sulfonylurea in the United States is usually a 10 cents a day medicine. These Sgl2 inhibitors or GLP-1 analogs are somewhere between $10 and $20 a day medicine. And again, that is some of the benefit that you can get from these interventions. So we don't do everything for everyone. We need to figure out what combination and sequence of cardiovascular risk reduction interventions makes sense for each of our patients. Then we get to glycemic control, and here's another shared decision-making tool that we developed a few years ago, this time based on issue cards, where we can ask patients, which aspect of your next diabetes medication would you like to discuss next? So let's imagine the patient's already on metformin. Their A1C is, I don't know, 8.5. They're having some symptomatic hyperglycemia. They need to bring that down. And they need probably they've tried diet and exercise and low carb and keto and who knows what else. And they need a new medicine. So this helps them choose a new medicine rather than use that sophisticated algorithm. So the patient might choose a medicine that helps them with weight loss. And as they consider the options, they're already on metformin. They have 2 medicines here that help them lose weight, they're interested in those, then as a clinician you might ask, oh, cool, which aspect of those two medicines would you like to learn about next? So the patient may be interested in learning how you use them. They will find out that this is an injectable medicine and this is a pill a day. Oh, great, pill a day, weight loss, I'm in, this is cool. Okay, what aspect of that particular medicine would you like to discuss next? How much will it cost? And I already told you that this is where the patient finds out that these medicines are way more expensive than the metformin that they're used to. At that point, the patient's eyes might go back and look at that other weight loss medicine and realize that it's not just an injectable drug, but also very expensive. They might decide they can't afford weight loss, maybe weight neutral will be all right, pill a day, that sounds really cool, but these are also very expensive. So they might settle for sulfonylurea with a little bit of weight gain, a pill a day and 10 cents. But a patient that is not so sensitive to cost might already have decided that this was a right medicine for them. Of course, the clinician doesn't play dead during this time, but there is actively involved in helping the patient figure out what to do, particularly by listening. Why is it that the patients are choosing these cards? Because that gives you a sense of their understanding of the situation and of their values and preferences. There is a version of these cards now that is electronic, where we've tried to mimic the interactions that we can get through the cards, and you can find it on this web. So by the way, all the tools that I'm showing you are freely available, and anybody can use them anytime. So we get to the end, and the patient is not doing well. Do we intensify the treatment? Otherwise, we get labeled as having clinical inertia. Or do we seek about minimally disruptive, to minimize the disruption of care? So I'm going to show you what that looks like. We're going back to this workload and capacity imbalance. What can we do to manage the workload? Well, we can prioritize the care. And here again, shared decision-making, like the kinds of interactions that I have demonstrated to you, might be helpful in sorting out what aspects of the care should stay and which might go. Practicing based on the platinum rule might be helpful here. You may be familiar with the golden rule, do unto others the way that you would like done unto you. But the platinum rule is more powerful. You have to do unto others the way they would like done unto themselves. And so that requires you as a caregiver, as a clinician, to be curious and get to know the patient and what they would want in this sort of situations. We need to ban medical errands. This is a bad habit of healthcare organizations that try to gain efficiency by fundamentally transferring work to patients and not paying them. And then we need to work towards lean consumption. A lot of our hospitals and health systems are working on lean production and trying to reduce the waste in their systems, but that effort stops at the door. And we need to also reduce the waste that is introduced into patients' lives by systems of care that are highly bureaucratized, are difficult to navigate, and waste patients' time, waste patients' precious energy and attention. What to do on the capacity side? My colleague Casey Bamer has developed a coaching approach, particularly designed to boost capacity in patients with chronic conditions. Capacity coaching and early in the trajectory of chronic disease, self-management training could be quite helpful in making sure that patients develop the mastery that would then allow them to know where to cut corners, what exceptions to take, become an expert patient. And of course, some of this training is best done by other expert patients. Palliative care, very important. I told you about how it's very important in patients with chronic conditions to care for their symptoms. You know, if they have insomnia or pain or shortness of breath or fatigue, these things reduce their capacity to take care of themselves and to do the things that they love in their lives. Psychotherapy, physical therapy, occupational therapy are important in bringing function back from disability. And social work, essential folks to mobilize community resources that can help increase the capacity of the patients to shoulder the work of living and being a patient. So this is a summary. This is, I no longer call it my clinical approach because the BMJ in 2019 published a paper from some of my colleagues in which some of these approaches now codified with some of the evidence supporting it reviewed. So I recommend this paper. But it really is about looking at what is burdening the patient in terms of the illness, what is burdening the patient in terms of the treatment, This is not in one disease, but across all the conditions that the patient has. To look at health behaviors, diet, activity, but also at allostatic load. Under what pressures is the patient? What is stressing the patient? Is it the social isolation from COVID? Is it the racism and discrimination of gender that might be existing in their communities? These things contribute to making them sick. We look at cardiovascular risk. We look at glycemic control. And then we look to make sure that in our efforts to help respond to the patient's problematic situation, that we have not exceeded their capacity, that we have not disrespected their precious time, energy, and attention. And so as we come back to Maria Luisa, we have to remember that all of this that we're trying to do is to care for her. So it's helpful to think about care. Not in terms of all the adjectives that tend to be banded around, sick care, health care, patient-centered care, evidence-based care, high-value care, but really focus on the noun, or perhaps even on the verb, care. And care is to notice that the person that we are attending to has a problem, and care means also to respond effectively, compassionately, and competently, produce a response to that problem. So we need to notice and respond. When we approach the patient, our only intention should be to care for and about them. And in doing so, we will develop relationships of care that will actually help us deal with the usual adversities that are common in the trajectory of life. This will be easy, but unfortunately we work in healthcare that has become industrialized, in which it is very difficult to appreciate the patients because they're often nothing more than a blur when they come to our offices. We see them too quickly, we see them as a test result, we see them as a statistic, or we see them as a data cloud. Our agendas are packed with things that we must do, document, certify, and document and complete, and then perhaps there's time for the agenda the patient themselves might bring to the office. And our clinicians are at a loss, unable to connect with this cloud that replaces the patient. They are losing connection with the purpose, with the reason they came into healthcare. The statistic is very easy to remember. 40% of our patients are reporting unsustainable levels of burden of treatment. We're overwhelming our patients. 40% of our time together is spent looking at the computer and feeding the electronic record and the data fields that it demands to be fed. And 40% of our clinical workforce is experiencing symptoms of burnout. Symptoms of burnout that include depersonalization and the inability to respond with compassion. This is what industrial healthcare is doing, and we need to turn away from industrial healthcare towards careful and kind care. Careful and kind care that hinges on our relationships, on our ability to have unhurried conversations. These are not long ones. These are just respectful of the tempo of care, of the pace of care, of the rhythm of care. These are conversations in which the music is not accelerated, where you can still recognize it, but you can no longer dance to it. Unhurried conversations allow us to see the patient's situation in high definition, in its biology and its biography, and to respond, producing a sensible solution that makes intellectual, emotional, and practical sense, because noticing and responding is care, and that is what we're called at the bedside for these patients. I've summarized some of this work in this book, Why We Revolt. Again, I don't derive any income from this, but when you read it, it goes a little slower than this presentation, so it might actually be more amenable to your enjoyment. And with that, I would like to stop and to be ready to answer any questions you might have. And of course, thank you very much for your attention.
Well, Dr. Montori, amazing presentation. On behalf of our partners, the Therapeutics Initiative, and the participants on tonight's call, we thank you so much for sharing your knowledge. You're so easy to listen to and have so much great information. We really appreciate it. And with that, I'll get right to the comments and questions. One comment, at our Community Health Center in East Vancouver, we need a dietitian who can teach our patients how to put together a nutritious diet from a dollar store, for example, starting where people actually are at, while advocating food and income security. So that's just a comment. A question, do you think we could do more subgroup analyses from observational studies, real-world data for example, subgroups of frail patients, patients with certain comorbidities. Do you have any thoughts on that?
Yes, I do. I think it's a huge temptation to take real-world evidence, as observational studies are called now, and then on top of that, look at small subgroups and see what they can tell us. It's a huge opportunity to be misled by chance. It's been helpful sometimes to pick up clear safety signals. I'm very uncomfortable with using them to pick up harmful, beneficial signals. Keep in mind that I can have access to that data in my desktop computer, and now since most researchers are working from home, they probably can do it in their underwear at home and run all sorts of analysis. If they find nothing interesting, nobody will ever find out. And so when you see a publication of a subgroup analysis observational study come up, it's because somebody thought it was worth publishing. In other words, they found an interesting result. And so that is the possibility of publication bias and being misled by chance is massive. I think we need to develop a much stronger culture of clinical trials in practice, where as we take care of patients, we decide together with patients that contributing to knowledge is part of the way we take care of things, part of the way we respond to the problematic situation of patients. And then patients and clinicians enter into clinical trials as they practice medicine. Some of the better answers for how to treat COVID have emerged from a commitment like that, for instance, in the UK. But we are culturally way behind on this progress, and we're trusting algorithms that are derived from such real-world evidence and artificial intelligence probes that are coming out of that evidence to actually begin to replace the knowledge that we can get from properly conducted research studies. So as you can tell, I'm a little bit concerned that we may not get the knowledge that we hope from the data that we generate in practice.
Interesting comment. May I ask, when you've mentioned that to patients, that part of the way we care for you is by contributing to knowledge, how do they respond?
I think in general positively. The thing that turns them off, frankly, is that we have now gotten used to the notion that we can contribute all we want to knowledge, but that doesn't result, at least in the United States, it doesn't result in better access to care or more affordable solutions. So all my contribution to this knowledge doesn't get translated in better healthcare for everybody. In fact, I mean, even at the more meta level, the more impersonal level, the NIH, which is a taxpayer-funded entity in the United States, is very similar to CIHR in Canada, has produced some of the most important insights in Medicaid that then led to commercial products and medications, and yet taxpayers are once again on the hook to pay for the price of those medicines, even though they contributed to actually their development. They're investors, right? And they get nothing for their investment. So I think that to some extent that takes away some of that sense of community and trust that is necessary to participate in clinical trials. So that's why I mentioned the word culture, because I think it's not just a matter of getting patients to participate in the trial. We also need to make sure that the ecosystem produces not just evidence, but direct benefit to patients like the ones that participated in the trial.
Very interesting. Okay, a couple of other comments. Unfortunately, because your work is so valuable, we've had requests to collaborate on a Canadian and an Australian version of your decision aid card. So
I can presume that the translation to Canadian is going to be particularly hard. So yeah.
Very true. Okay, let's get to some of the other comments. One other comment: if the federal government in Canada delivers on their throne speech to produce a national pharmacare, that might eliminate or reduce the cost factor in the decision-making process.
It may not. It may not. So it's interesting because it would reduce the out-of-pocket. I mean, that would be an enormous. That's obviously the natural progression of Medicare in Canada, right? They should go to pharmacare for sure. But I think what countries that make progress in the direction of solidarity find themselves doing is they become increasingly aware of the community cost of those programs of care. So it may be that the conversation gets gets, I would hope it does, gets turned from the individual cost, the out-of-pocket cost of these interventions, to the community societal cost and the cost and the opportunity cost of investing in this particular set of treatments and drugs versus other programs that are of national and community importance. So I hope that the cost issue that goes away is the out-of-pocket discussion, which will be a great relief, but the cost issue that comes to the fore then is the cost for the community, for the society, for the country.
Interesting. Okay, we've got a comment here about seeing some progress in the past where we moved away from checking blood glucose in type 2 diabetes but now with the advent of technology, continuous glucose monitoring and flash, it seems like we're slipping back. Do you have any comments on how these technologies have impacted your practice?
Yeah, for patients that are on intensive insulin therapy, even patients with type 2 diabetes, particularly the flash sensors have been a massive improvement in burden of treatment for many of our patients. I'm always very surprised to see patients walk into my office for consultation who have a very mild form of diabetes. They shouldn't be checking their sugars, and yet they're using one of those devices and have an awareness of the minute-by-minute variation of the glucose levels. And they've developed all sorts of theories about how food and activity contributes to those variables, which unfortunately is likely inaccurate. So, so yes, I think I actually like the fact that some of the technologies associated with diabetes care have become a lot more user-friendly, such that people are now volunteered to use them. When in the past, I think people will probably run away from them. But the truth is most people with type 2 diabetes that are taking one or two medicines, particularly those that don't cause low blood sugar, probably don't, more than likely do not need to be checking their sugar. Certainly that doesn't improve any outcomes. And some of my patients, particularly those who have an engineering background, like to know what their numbers are and so forth. And that gives them a sense of control that contributes to their sense of health. So I tend to play along, but for the most part, I don't recommend it for people who don't need it.